specifically concerning personalized medicines and AI. We're very pleased to have as our witness this morning Preet Kaur Gill, who is the Parliamentary Under-Secretary of State, Department of Health and Social Care. And with her are two of her colleagues, Fiona Bride, the Interim Director General for Commercial and Growth, Department of Health and Social Care and NHS England, and Rob Thompson, Chief Digital Data and Technology Officer, Department of Health and Social Care and NHS England. Thank you all for coming. We have quite a number of questions for you. So as you know, our inquiry has chosen to look at innovation in the NHS through the lens of two major healthcare technologies, personalised medicines and AI for healthcare. And the 10-year health plan describes an ambition to, and I quote, establish a genomics population health service and make the NHS the most AI-enabled care system in the world. So the first question that we have is what are the government's ambitions for these two technologies, and what progress are you making to deliver on these? So, Minister, would you like to start?
Yes, thank you so much, Chair, and thank you for the opportunity to give evidence today. As you know, we're at a really important moment, I would say, for the NHS, because innovation isn't just about new technology, it's about how do we actually improve outcomes for patients, how do we support the workforce, and how do we build a health service that is able to prevent illness earlier and clearly deliver care more effectively. And that's the premise by which I approach this. I think when we talk about innovation, I think it is important to separate the two areas. Whilst they're often discussed together, and I get why they are, but they're not the same. You've got personalised medicine, and then you've got artificial intelligence. And so they are both built on, of course, the advances of science, of data and technology, but I suppose they answer different questions. So let me take those separately. So personalised medicine is about patients getting the right treatment to the right person at the right time. And we know that healthcare has often relied far too much on a one-size-fits-all approach. But every patient is different. You know, our genetics, our biology, and how we respond to treatment can actually vary significantly. And I think the opportunity to use some of the advances in genomics and life sciences to better understand these differences so we can actually predict risk earlier, we can prevent avoidable harm, and we can provide treatments that are far more effective for individual patients. And that's why personalised medicine, as you said, Chair, is such an important part of the government's 10-year plan. And I suppose a good example of this, because I think it's always good to kind of have a real-life example of like what does personalised care look like. Pharmacogenomics is a really good example because we know that some babies, for example, carry a genetic variant which puts them at a much more higher risk of permanent hearing loss if they receive certain antibiotics, for example. And that the work that the NIHR, the Manchester Biomedical Research Centre did, is that we now have a rapid test that can identify that risk before treatment is actually given. That's really, I think, a powerful example of what personalised medicines means in practice. And then we're also seeing huge opportunities in cancer pathways, and I'm sure your committee has heard some of that evidence, but the NHS Cancer Vaccine Launchpad, which was established 3 years ago, is actually helping accelerate access to personalised cancer treatments with clinical trials. And we're working with industry partners like BioNTech, for example, and we want to provide up to 10,000 patients here in the United Kingdom with personalised cancer immunotherapies by 2030. And patients that are undergoing treatment, for example, at the moment can access clinical trials. That is really important, that they have the opportunity to be part of trials. It widens access, of course, across NHS trusts. And then artificial intelligence, as you said, is quite a different opportunity. And I want to say and make it clear, AI is not about replacing clinicians, because far too often this is a concern, and a genuine concern which I take on board. But it is about giving clinicians better tools. whether it's making decisions, whether it's reducing some of the unnecessary burden and freeing up some of their time so that they can focus on patients. And a good example of this at the moment, which I'm very excited about, is ambient voice technology. This is supporting clinicians by helping with note-taking during appointments. That means they can have eye-to-eye contact. They can be actively listening with patients. At Manchester University NHS Foundation Trust, the trials have suggested that we're saving around 5 minutes per patient. I mean, that might seem quite small, but actually, if you think about the millions of appointments, it means that actually clinicians can spend more time on care, for example. And NHS England is supporting some of the safe scaling of these technologies through the Frontline Productivity Programme, which is starting in outpatient settings. And we're learning what works before we roll it out. And I think that is really important. That is the approach we want. We don't just want pilots that never spread, but innovation that is properly evaluated and then it's adopted at scale, and that is the approach that we are going to be taking. I want, and the government wants, the NHS to be the most enabled AI health system in the world, and that ambition has got to come with responsibility. So let me finally, before I bring in my officials, say the question isn't just simply, can we use AI? The question is, how do we use it safely? How do we use it effectively? And in a way that I suppose patients and clinicians trust, because that is really important. So the key challenge, I would say, is that AI can change over time. We see technology advancing far quicker than we can keep up to date. So one of the things that we're doing is we recognise that a single assessment at one moment is not enough. And that's why we need a kind of a life cycle approach to how we adopt AI into the NHS. That means assessing it before deployment. It means monitoring how it performs in real NHS settings. So we have examples, understanding what are the benefits and what are the potential risks. And ensuring that we are continuously evaluating and have clear accountability, because I know that this is the thing on many constituents' mind when I speak to them about their data and about what happens. So the evidence threshold has got to be proportionate, but I recognise we need to enable innovation, and that's why the work on the National AI Roadmap. This is the regulatory framework, and it's Professor Alistair Dennison's review are going to be really important in actually helping us build a system where innovation and safety move much more closer together. I think, Chair, the opportunity is really significant. I think personalised medicine just allows us from treating the average patient to treating the individual, and both are essential to the future of healthcare. And
Thank you very much. Can I just ask, before we move on, your 10-year health plan promises universal newborn genomic testing and population-wide polygenic risk scoring. But in both these cases, there is a scientific and medical debate about how useful those measures will be. How are you gathering evidence on this, and how are you assessing the threshold at which the government will begin to implement these measures?
Yeah, as I think I've already said in my remarks, it's about the continuous evaluation before there's wider rollout and adoption, and so assessing what are the opportunities, what are the potential risks. Clinical trials are really an important part of the work that we are doing, making sure that we have access to innovative medicines, but equally the genomics around prediction is really, really clear, and there are quite a lot of safeguards. I don't know if you want to say something on that.
And I think, certainly the Genomic Medicine Service and how we bring that data together is a really fundamental part and an investment that this government's made to ensure that actually we iterate carefully, and I think with the right MHRA safeguards. I know you heard from Lawrence Talon previously, but I think it is about stepwise iteration, and that's how the research will allow us to progress. I think what you talked about in terms of some of that pharmacogenomic aspects and how we start to risk score assess is also a separate entity, and that is the role that AI, I think, will help us to learn as we go and inform the decisions over the next 10 years.
So do you anticipate polygenic risk scoring as happening really quite soon?
I think we need to be careful in terms of how we move, but as we see with most AI iterations, there is a learning process, and as we embed some of those learnings, we will look at how we progress.
Lord Winston, you want to come in?
Very briefly, could you tell us where you think AI is already working well in the health service?
Oh, there's loads of examples. I'll bring in the officials. I mean, I've been to the Royal Surrey in Chelsea and Westminster Hospital. I've seen the FDP being utilised. This is a federated data platform. This is about helping clinicians see their data in real time, bringing it all together. So how GPs interact with consultants by referring someone onto a waiting list, for example, through the EPR system. The consultant can see that referral in real time, give advice back to the GP and say whether they should be on a waiting list or not. And then the system enables a clinician to input them on a theatre utilisation list.
We get the message. Thank you very much.
Yes. But also chest X-rays. I mean, I went to visit how we support lung cancer, for example, screening what the human eye may miss on an X-ray machine.
That's lung cancer.
Sorry.
That's lung cancer.
Lung cancer, that's right. It's an AI tool, it's an X-ray tool, which is a second pair of eyes for a clinician. So there is lots of examples, and I'll bring in Rob as well to share some of those.
Would it interest you to know that most radiologists are absolutely crying out for more access to AI, where there are a whole range of radiological investigations, as there are also in pathology, for example, where AI is already being used remarkably successfully, and it's reducing a number of mistakes and increasing diagnosis more effectively. What it doesn't do is screen. It's not good for screening, which it might be worth bearing in mind. That's what they're saying to me anyway.
Right.
And I think there is a real need, actually, to understand why this is so poorly supported in the health service, because currently it is.
So can I just say, I mean, it's in half of the trusts at the moment, and you're right, we want to have full rollout by the end of this Parliament so that everybody benefits no matter where they are. I spoke to clinicians that are using it in terms of, things that were missed by the human eye, and you're absolutely right, it's an absolute game changer.
It's a bit more than...
It is more than that, and I'm simplifying it to you, but yes, of course, the technology can do so much. And that's why we need to see adoption. And of course, adoption varies across the country because different ecosystems and different IT abilities exist. But of course, the rollout it should be on the chest X-ray AI by the end of this Parliament.
Lord Duncan wants us to come in.
Okay. I want to pick up on Ms. Bride's point about the risk register and the concept there. How is the risk register generated? What is the genesis of that? Because I can see a medicinal part of that. Yeah. Is there also an economic part and a political part which you are alert to?
I think at the moment we're very much looking at this as patient outcome perspective from the health merit that it brings. I think clearly as we see, and in fact in the obesity arena, we're already starting to look at what's the productivity impact and collecting some of that data. There's a really strong initiative up in Manchester already looking at collecting different data. I think as we progress, again, it's about learning as we go and not having it all written down. I am absolutely sure there will be wider benefits that we will bring in.
I have no problem with the benefits, I have no problem with it being patient outward, but we've already had evidence that much of this technology, this innovation will be quite costly, and you will hit up against buffers very quickly, because the notion that you could do a national rollout of almost any individual part would be quite unlikely. So within the risk register, you must also be looking at the economic constraints of what will be extraordinary innovations and extraordinarily powerful outcomes, but may actually hit up against there simply not being enough cash.
And I think like most innovations, what we need to, and maybe it comes to the point of adoption and where we really focus, we need to be clear about the priority demand signal, if you like, that the NHS must serve to solve. And I think when we look at the modern service framework as a recent initiative really transforming the outcome in, say, cardiovascular disease as a priority, what are the outcomes we want for patients in the next 10 years? What are the innovations that will really transform those pathways? That's where I think we will bring all of this innovation to transform that patient pathway as a priority.
We will be coming on to funding innovation just in a few questions' time. Mr. Thompson, do you want to come in?
Yeah, I wanted to pick up on some of the AI points. It's a really rapidly developing technology. I think you all know that. I think the public know that as well. but its application is very specific around the specific use that you want to apply it to. And that, I think, is where some of the complexity is. And you can't just take AI and uniformly throw it at a system and then expect it to stick. You have to look at specifically what you're trying to do. And I'll give you 3 different examples of work that we're doing right now, just to highlight the difference. So I'm going to come back to the ambient voice technology element. So, fantastic piece of labour-saving technology there. My visits to acute and general district hospitals has been unequivocally supportive of its deployment. When I speak to clinical people in emergency departments and elective care, they are both very, very adamant and can demonstrate that as a labour-saving device it is highly effective. That's very, very different to a speech-to-text old-style piece of technology. It's able to identify context and communicate and summarise in a really elegant way, and demonstrably probably 2 to 3 minutes time saving on a 10-minute consultation for elective, up to 30 to 50% time saving for the clinical person in an ED department. The most important point that is non-efficiency is the removal of the cognitive load on the clinical person, though. That's the thing that really jumped out at me. Instead of them being sat there trying to listen to somebody while simultaneously trying to diagnose and understand, while simultaneously trying to figure out what it is they might type, whilst also simultaneously typing, they're able to give the person in front of them their whole attention, that the patient has a better experience. They can enact their job in a far more effective and elegant way as well. So I think there's a really qualitative, beneficial aspect to AVT. I would say it's not a particularly sophisticated application of AI, but it is very, very productive and useful. And I think that underlines probably where, in some regard, the health system is at the moment. We are in the foothills of using AI. We're exploring where we can use it most effectively, and understandably one of the areas that we turn to most quickly is in and around productivity and efficiency.
Okay, thank you. The next question is coming from Lord Booth, who's coming in online.
Good morning, Minister Gill, and to your colleagues, and thank you for coming to give evidence to us this morning. My question is about the failure to scale pilots across the system. And we continually hear in this inquiry that the NHS struggles to adopt proven innovations, that it can take between something like 9 and 16 years for clinical research findings to enter routine care. In particular, we've heard about the so-called valley of death between piloting a new innovation or medicine and procurement of that innovation becoming routine. And often trusts can afford to do the pilots, but their budget for adopting innovation as a routine is much more limited. This is not a new problem. What is the government doing about it?
Yeah, no, thank you for your question, Lord Booth. This is really an important question, and it's the one thing that I've been picking up because we're brilliant at innovating. There is no shortage of our brilliant science, our researchers, our SMEs or startups having that innovation, but it's the scaling of pilots, and it's the adoption within the NHS that we are clearly struggling. So what are we doing nationally? Well, we're putting in place the infrastructure so that the NHS can identify, it can assess and adopt proven innovation faster. We already understand the barriers. I'm sure you understand, and I'm not going to go through them. The Life Sciences Sector Plan is a year on. And this is the year for delivery. It is an absolutely ambitious part of the industrial strategy. It's an area of growth, health and tech. It's certainly an area that the government takes very, very seriously because nobody wants to see a product just be in a pilot, because if it improves outcomes, if it reduces pressure on staff, if it saves money across the pathway, then systems do have to recognise that value. And I think, there is an ad hoc approach in different parts of the country wherever you go. And that's why, the department has published the value-based procurement guidance. And that's just simply, the whole purpose of that guidance is about moving away from what does something cost, because I think we do get caught up in cost as per recognising, well, what value does it actually create for patients and the health system? And that's the question that I want us to answer. We're also creating much more clearer innovation pathways. I have lots of medtech companies in my constituency, for example. I know, we get this question from SMEs about, we've got this brilliant product, but I just can't get it into the NHS, and it's not quite streamlined in the way that medicines is, and the pathway is quite clear. We don't have that for health tech. And that's definitely something that we are going to address. And so I think the new rules-based innovation pathway for medtech, including the National Health Tech Assessment Programme, we're creating that. It's a much more clearer route. What's the aim? It identifies what works. It assesses it properly, so making sure that NICE, MHRA, it's gone through those processes. And then we want to support adoption at scale. But it also means moving away from every trust having to repeat the same assessment of the same technology, because honestly, that has been a big issue, and we don't want everybody doing that. So I think trusts are going to be really central to seeing this come into fruition. And then we've got 15 health innovation networks across the country. They work locally, regionally and nationally. And what do? Well, they identify and test and spread information. That's their whole purpose. They help organisations understand, well, what is the problem that we're trying to solve? Whether there is evidence that the technology works, because clinicians can be very sceptical, as you know, but also how do you implement it safely, and how do we share learning? Look, I've been to some amazing hospitals in Royal Surrey and Chelsea and Westminster, and robotics is really exciting, and seeing a prostate cancer surgery, but I want clinicians to share that best practice so other parts of the country benefit from clinicians saying that this technology is really good, this improves pathway. We've got to bring the investment into areas. And then just to there is a lot we're doing, and that's why I'm taking a bit long to answer the question. But we've then got the NHS Innovation Accelerator, and that's helped scale more than 100 evidence-based innovations already across England. So we've already got that. And those innovations have reached over 10 million patients, with around 3.5 sites using NIA innovations. And there's been about 243 million external funding that's been raised to really support that. That shows that we can scale. And that, we now need to make that the norm. That's what I want to do. This is not the exception. This has got to be standard NHS business that we are looking at. And then I would say there's another programme called NHS Insights. What does that do? It brings 18 member organisations representing about 155,000 staff with over 35 million patients to build skills and capability around innovation adoption. There is no point just having the adoption. We've got to have the skill sets in those places so that they are able to adopt that innovation, but clearly be able to say whether it's working, whether it needs changing or reviewing. And that includes hospitals in places like Birmingham, in Bradford, Leeds, Essex, Newcastle, and Milton Keynes. A good case study I want to give you about AI reducing missed appointments is in Mid and South Essex NHS Foundation Trust. They've got an AI solution to reduce missed appointments and improve waiting times. So Deep Medical's AI was integrated into patient communication system, and it analysed patient data to offer alternative bookings. And that contributed to nearly a 1/3 reduction in missed appointments. And NHS England is now planning further expansion across many more trusts. So that journey from evidence, adoption and scale is not something we just want in one hospital. We want that learning to be, that adoption and that scaling of pilots to be much more uniform across the NHS Trust. I'll probably stop there in case you've got any further follow-ups.
Well, I have got a question, Minister. I think what you've very correctly done is to identify the problem. What we're interested in is how to solve it.
How to solve it.
And Professor Andrew Beggs, who's an academic at Birmingham, and you perhaps know him through your constituency.
I do.
When he gave evidence to us, he said there is a local problem. He said is that whenever you take an innovation into the NHS, the first answer is always no. What's your comment on that?
Yes, I would say in week 7 of this role, absolutely right. I'm hearing this. I did the industry engagement yesterday. I've got an industry roundtable with Health Tech later on today, and that is exactly what I'm being told, is that the pathway, and the pathway is the solution that I've talked about, and apologies if it wasn't clear, is about helping companies get access into the NHS through adoption. Some of that is national, some of that will be local and regional, because the ecosystem that exists will be different in different parts of the country. And certainly accelerating, once they've gone through NICE and MHR processes, it will be much more easier to procure and adopt into the NHS. I recognise the concerns that are being raised, and we've got to move at much faster pace, because nobody wants to see innovation not reaching patients. That's the whole point of all the innovation that we're doing, and we've got some remarkable work in this country. We just need to get that into trusts and adopted much more widely, and that's why I think the clinician voice of sharing good practice really does help that. And unfortunately, there is a lot to do in this space. So I do take that on board, and I rest assured we are doing that, and I'm happy to come back and update you on the work we're doing.
Thank you. Lord Willis is coming in online.
Well, first of all, thank you very much, and good morning to you. I was particularly pleased that you said brilliant. England is brilliant at innovation, and then you went on to say that it needs to be spread to all patients. And my concern is, how do we ensure that all patients, wherever they are in England, actually can benefit from innovation? And it comes back to the issue of funding this nationally. The 10-year health plan sets out a vision where a shift to prevention, particularly achieved through technologies like genomics or AI, secures the sustainability of the healthcare system for the future. But at the trust level, innovation has to compete for funding, and other types of transformation and transformation budgets themselves are often redeployed to cover spending pressures. So the vicious cycle is that trusts are often unable to invest in innovation that could make them even more efficient. My question to you is, how are we intending to get rid of that?
Yeah, no, that's a really important point. And so let me just be clear, there is the AI Diagnostic Fund. This is just one example of a funding pot that is available, and I appreciate there are a number, because the Life Sciences Sector Plan sits across DCIT and DHSC. But the fund has been deployed across imaging networks at the moment, covering about 66 acute and specialist trusts. And some of this is about supporting what I talked about, the innovation around faster lung cancer diagnosis. So there's already more than about 3.2 million chest x-rays and about 80,000 CT scans that have been processed through using some of these tools. And the evidence, as I've said earlier, shows that AI can help radiologists analyse scans in around 4 days compared with 6 days previously, and the most complex cases, helping patients get the answers much sooner around their diagnosis. And because of that progress, we recently announced a further 20 million to expand the AI chest x-ray tool, so that every NHS trust in England by 2029 will absolutely have it adopted. That's taking what works, what's proven, and then showing that actually we can roll it out and scale it up so that every patient, no matter where you are in the country, you should absolutely benefit from that. We're also investing 8.1 million through NIHR, which is part of my department, the National Institute for Research. And what we're doing there is we're testing 6 more AI and digital technologies across the NHS site. So this shows you what we're doing nationally. We're taking innovation. We're now doing this pilot on 6 further AI technologies, and these technologies will support the NHS staff. So what are we looking at the moment? We're looking at analysed CT scans, ECGs and X-rays, and we're also looking at digital therapies. And what we're doing is identifying the most urgent patients for prioritisation as part of this pilot. And if this then works, then as we've done with the chest X-ray, it is about how do we then scale that and make sure that adoption and innovation benefits patients across the country. So the focus, of course, has got to be, because there's so much innovation and there's so many different areas. At the moment, the focus is on heart failure, stroke, lung cancer, lung infections, and tic disorders, I think, where we know in these areas faster treatment actually saves lives. And that's why we've got to do this prioritisation. That's why we've got to do this national rollout. So I want to assure you there is funding commitments there that takes that innovation, that looks at the safety of it and the adoption of that much more broadly.
Thank you. Lord Winston.
Can I just say to you that when we've spoken to a number of people with this inquiry, in our hospitals, within our practices, are not there for significant numbers of people. Is there a decision by the government to say everybody must have the basic technology, full stop?
Yes, absolutely. I mean, look, there hasn't been a premise of mandating trust. I think what we are doing, I mean, Rob and I on the FTP, for example, will be writing to trust, telling them what 3 tools they must use in order to improve productivity, improve patient outcomes, but support clinicians in terms of that administrative role. You're absolutely right. Where we have proven technologies, they're rather than, if we have to get into the mandated space, so be it. But it is about showing trust about the benefits, and sometimes we're not sharing best practice. The fact that the FTPs can pull into a national dashboard, so in real time we can see how many ambulances are sitting outside a hospital, how many bed capacities is available, what's the theatre utilisation, how we're reducing waiting lists, so we're prioritising people not on how long they've been on it, but actually on the need around their medical need and prioritisation. So this is absolutely, I absolutely take on your point, and absolutely, I'll bring in Rob just to say that I'm very much of the view that we've got to absolutely, at pace, but be very clear what works and what we want adopted across the country.
Before you bring in Rob, could I get Lord Winston just to come in?
Hey, briefly, you mentioned robotic surgery. That's why I'm taking it up with you. There's been huge emphasis on it now for 30 years, actually. It's quite a long time. Can you say whether, in your experience, robotic surgery in randomized controlled trials is really significantly better than just non-invasive surgery, which actually uses laparoscopy or other endoscopic techniques? Because robotic surgery is very expensive. Maybe it's not being taken up for other reasons.
I think, this is about trust leadership as well. I mean, the Royal Surrey has 5 robots. I mean, they have decided consciously to make an investment into that. Now, what I found really quite remarkable, you are right, it's expensive technology, but if we think about the patient outcomes, it means that patient can be discharged on the same day. They won't occupy a bed for 4 days or 5 days, whatever it is. But the best thing about it was that the prostate, when it was removed, could there and then be analysed to check whether all of the cancer cells around it had been removed. So the patient does not have to then be brought back and then have a further operation because, something's been left and actually it hasn't all been cleared.
That could be done with non-invasive surgery.
Well, if we look at it from a patient perspective, the patient will have to have 2 operations as opposed to having 1. The patient will be able to go home on that day. That means we're saving a bed for about 5 days. If we start thinking about it from the patient perspective, the patient outcomes are absolutely clear. The thing is, the more we start doing something and investing into something and bringing the cost down, and it becomes quite normal practice, I think, that is where we need to get to, is showing trust that actually investing in robotics, how many more surgeries can you do as a result of that versus having to wait for surgeons? And we know that cancellations happen all of the time for various reasons, but the idea that you can in real time know whether that surgery's been successful, so you're not having to bring the patient back again to have a further invasive procedure, I think is so important.
We talk about non-invasive, which means actually using the same instruments, but having the advantage of the surgeon not being separated from the patient, but actually connected to the patient. And that makes a very big difference. Actually, that shortens the time rather than lengthen it. On the whole, I mean, I've watched robotic surgery in this country, in America, in Calgary, for example, in New York, and many other places as well, because I'm interested in that area. And on the whole, actually, it's extremely complex sometimes. And I'm still convinced that there are good trials which show that it's really justified. And though, of course, when I look at your literature that comes from the Department of Health, I see there's a huge focus on robotic surgery, and I sort of wondered what the scientific basis for that was.
Yeah. No, I accept your point, but I think that this is where we need clinicians talking to other surgeons across the country as to what they see as the benefits of that. There isn't much of that happening. I mean, it can't just be that the Royal Surrey is where everybody wants to go for certain procedures because they have access to this robotic surgery, and that it's proven, by the way, in terms of
practice.
Or private practice, exactly. So we've got to look at what is the investment. Equally with the CT scans that are AI enabled. That's why we want to roll out the chest X-ray. So I think where innovation is showing it works, where it can improve productivity, it can have good patient outcomes, it can support clinicians in terms of doing more capacity for theatres, for example. It's the evidence base that we need to see as to why then we should put the investment into purchase, which is very expensive, as I hear what you're saying, and I hear that surgeons, for non-invasive, it can be complex, but when I went to the Royal Surrey, all of the clinicians are in the room and absolutely checking with the patient. They're on side, of course, they're managing the robotics, but very cognizant of what is happening for that patient. So, that clinician is not separated. They are pretty much directing, which I know you know. But I don't know if you want to add anything more.
Minister, I'm just worried we've got a great deal more questions.
Yes.
Can we move on?
Yes,
Lord Brayson
sure.
wants to come in.
Can I, Ms. Bride, could I just ask you, you as Chief Commercial Officer for the NHS, with responsibility for £30 billion spent, we've heard from witnesses, and it's sort of, I think, we'll accept, previously working in the pharmaceutical industry, it's well established that the NHS has a reputation for implementing schemes which are subscale, which give good announcements to be made by politicians. And the Minister has mentioned allocating 43 million for an accelerator, 8 million for a pilot. These are tiny amounts of money. So how do you square that prioritisation balance? You're making the decisions about where to spend this money. How do you defend that?
I think, this is a recognised challenge and we embrace it fully. I think it is widely recognised that we have not leveraged the value that the NHS can command as a national procurement approach. Now, what that doesn't mean is that we buy it all centrally. Clearly, the local decision maker holds much of the actual accountability for the finance. However, what we are starting to look at now, and we do this in medicines already, and I think we can learn as to how we approach this towards health tech and med tech in particular. Interestingly, robotics is one of the areas we will leverage this in. Because you can imagine if you are at a trust level procurement buying one robot, the ability to negotiate the best value is very difficult because you're buying one. If we can start to leverage an at-scale value procurement, as we do in medicines already, we set one national price, to actually enable the choice still to be local, the decision for the clinician to make, we recognise that we can then do much more of a value-based procurement focused more on outcomes and leveraging the at-scale procurement that the NHS, I think, should and can realise. But actually what that means is we have frameworks where we set a more national approach to that. That is work in progress. We are iterating. So we've currently started on some of the less high-tech innovations to look at how we help choice as well, so that we actually really focus on what best value looks like, not just about price, but actually the outcome it generates, and actually how we can embrace that at scale and pace.
Ernest Willis.
So I want to move slightly on, but I think some of these questions have already just slightly touched on. We've heard a lot about this pilotitis, where you've got these trusts doing these excellent pilot projects, and the innovations being adopted by one trust. But then you move to another trust, and they have to start all over again. And it's interesting that you're picking up on procurement, because that seems to be one of the really big blockages, or that's not quite the word, but quite the right word, but you know what I mean. It's so you begin all over again, and of course, if you are that life sciences innovator, then you give up in the end, and you have to keep going around the same circle, and with the variations that each trust wants something slightly different. So what can the government, or what are the government doing to ensure that innovations that have been adopted by one trust can then be rolled out across other trusts without having to go back through this loop again?
Yeah, I mean, through the life sciences sector plan, I think we've really sort of set this out in terms of, you know, what our plan is, and including our 10-year health plan. I think we've got a number of things that will address this, and I'll bring in Rob as well. The National Health Tech Access Pathway, that is supposed to identify sort of the well-evidenced technologies that meet some of the NHS priorities set out in the 10-year plan. And what we are supposed to be doing is support them through the assessment, through the NICE appraisal, and then get to adoption. It's taken on board your point that if something works, then all patients have got to benefit everywhere. And you are right, you know, it can't just be that one trust is procuring one thing and then we know that it works and it saves so much time, and then another trust hasn't. And that's why the national procurement on some things is really quite critical, as is the local stuff. But I'll bring in Rob to answer that further.
Yeah, so I'll bring it back to an AI context, because I think it's easier to see the change because the technology is moving so fast that it's forcing us to move fast as well, or certainly a lot faster than we used to do by all accounts. So National AI Roadmap, we've mentioned it already. It's about a structure. It's about putting structures in place that allow innovation to thrive and then propagate as appropriate. And under the National AI Roadmap, there are really three types of work. The first type of work is work that I and my team do myself, which are AI enablers that we propagate into the system. And as Minister said earlier, we're a little bit more, or can be more assertive about the adoption of it. So not really optional, but getting close to mandation for some things where we believe there's a lot of value. There's a second...
Can I just stop you there?
Okay.
So who mandates it? Who's the person responsible at the top to say, right, we are going to adopt this? Because what we're hearing from evidence is you'll have a clinician or a team of clinicians pushing back saying, oh, we don't want that here. Or even we don't have the bandwidth to take this on board. So there's a
yeah, so the structure for that would be that I would probably make a recommendation to Minister and Secretary of State, and then they would say yes, go ahead, or no.
I think there's also, just to come in there, Rob, I think one of the opportunities, you've already heard about the National Health Tech Access Pathway. As we see in medicines, when NICE determine the product to be cost effective, there is a funding mandate that attributes to that. The same will be true, and this I think is a major change, for any of the health tech solutions reviewed through NHAP will come with a funding mandate.
They'll behave like NICE in that
and
way.
that will... Now, not everything. I think some of the AI may not be appropriate to go through that. We need to look at a route B. We've already started that work. To start a bit as we see in medicines, where we look at national clinical guidance to inform. I think there are two other parameters here. One is national clinical leadership. So Dr. Frankie Swords obviously recently joined as the National Medical Director. She has joined the Innovation Board to ensure that that clinical leadership as a national voice is also heard. But also I think the innovation passporting, this speaks exactly to your point. What do we do once well to assure the system? But also then, how do we simplify what the system has to do to assure themselves that it can be legally rolled out? And there are two parameters that need to be done, but simplifying such that the poor supplier at the moment runs around 200 different people with different requirements. We have to eliminate, and I think there's a real commitment to that.
Can I just assure you, ministers are really, and the Secretary of State is really clear, because this has got to come from the top leadership. Whilst we want that flexibility around what's adopted locally, recognising that absolutely the national leadership has got to, identify the innovation that works, and that's some of the examples that I've given you. But I'm equally, as I said in week 7, very much of the view that there are some things that need to be adopted nationally, and so the work that we're doing is looking at that and engaging with trusts.
So can I go through the other two categories? So the other two categories are, well, the next one is where something is locally innovated, and then we look at it and we go, that has national worth. And then we move into a support role where we actually probably take the technology, work with the local area, and then look to propagate it. The announcement at the weekend around AI triage in the NHS app is a perfect example of that. So that was a piece of technology procured by a GP, I think there was a group of GPs in the Sussex area, covering 23,000 patients. We supported them in running a trial to see whether that AI triage was effective for them. And it turns out that as a result of introducing it, the amount of people in the queue on a Monday, Tuesday, Wednesday morning trying to get a GP appointment dropped by 30% because the triage activity was doing the job necessary to direct them to the right care pathway, whether that was self-care, go to a pharmacy, have a GP appointment, or go to A&E. We're now working with them about taking that technology, embedding it in the NHS app, which is obviously used by 41 million people, and then working that through for a national propagation. The next step for us is to do that in London with about 200,000 people. We'll get a larger base of evidence to suggesting the extent of the benefits, and then we'll move into a national rollout, which we anticipate in April 28. That's a 2-year cycle to go from a local innovation, where it was done discreetly at grassroots level, to a national propagation, and that is significantly quicker than the 9 to 16 years that I think I mentioned earlier in the discussion. So that's the second category. The third category is where we are asking local areas to innovate and helping them with the structures and technology to be able to do that, like getting the baseline tech in place to be able to support them. The AVT announcement, which was also part of the weekend, is an excellent example of that. Whereas I'm saying, giving them guidelines and saying, use AVTs that are integrated into your electronic patient record systems, because that's the best way of getting the data in. I am giving them latitude to be able to go and select who they want to trade with, who they want to buy from, and implement it locally. So we've got 3 different structures that we're bringing to life now, and I think that solves some of the issues that Lord Willis mentioned earlier about how do we avoid a future where people just do pilots and then nothing happens. It's because we are being assertive about innovating. It is because we're putting structures in place to help it.
I want to move on to the next question, but if I can just come back. Your third example, to me, fills me with dread, because to me, it sounds like you're going to have everybody trying their own innovations, but it, again, just be those areas we've heard time and again, the areas where you've got a university, where you've got people who are much more research active, and the areas which are often in the lower socioeconomic income bracket will be the areas that you don't get that local innovation coming through. So it does fill me with some concern.
In the detail of the AVT deployment, what we are putting out as guidance is that if you are capable of doing this yourself, and like Manchester is a good example where they are actually very capable of doing it, as are many of the advanced trusts, that's fine. But we will provide financial support and expertise and change and transformation support for those areas that are not able to do that right now. So there is additional financial support to help that.
You've got more questions?
Well, I've just got the next two.
You be as brief as you can.
I'll be very quick. I mean, I suppose it's easy to keep saying what are the problems, but I mean, that we do have examples where things are working well, and one of them being genomic medicine service, where you've got that national commissioning model delivered regionally through hubs. So that's sort of top down. And will the government consider extending that sort of approach? Is that in your plan?
Yeah, I mean, I think, so just to say, last month, I think the NHS Genomic Medicine Service reached the milestone, I think, of 200,000 whole genome sequencing since obviously the service was launched. And I think it's something like more than 52,000 whole genome equivalents were sent for sequencing last year and this year. This is personalised medicine, I guess, in practice, right? So yes, absolutely. I mean, it is building on the evidence base of the research of what we're able to achieve and being able to then sort of roll that out more broadly, yeah.
And maybe just to add, I think, where we look at personalised medicines, often rolled out through specialised commissioning routes with central funding, we see the uptake of that innovation transformed in terms of consistency and equitable patient uptake. Now, it is not appropriate, I don't think, that we're going to suddenly have all of the medicines funding in one central place, and clearly local delegation of that fund is important. However, I think that is the opportunity as we move towards a more maybe prioritised, demand signalled, how do we give greater clarity? I think the single national formulary is a significant step forwards there. The last analysis we did, we had 51 different ways of categorising whether a medicine that NICE had endorsed could or should be used in a local situation. The single national formulary will stop that variation and enable a one clear sense of formulary approach. So I think there is a step towards whilst not having everything centrally.
Okay, one more question, which is about innovation metrics. So, I mean, I think, we've heard a lot about what's going to happen, but there's nothing like a target to make people actually focus on what they're trying to do. So is there a sort of an idea of embedding KPIs for innovation within the National Health Service?
I think so, yes, but they're not specific at the moment, if that makes some sense. So what we're typically doing is trying to draw a line back from the innovation activity to performance against statutory measures, so the 18-week RTT figure or the 4-week ED figure, and also trying to codify performance benefits writ large across the system. There is nothing in the plan currently to say we are going to specifically do KPI A, B, C, D for innovation. I think that is largely down to where we are in our own development of the National AI Roadmap, the strategy and plans for it, but I do concur that it's a good thing to do.
Lord Drayson, I think we've covered the questions that you were thinking about asking in terms of who in the NHS takes responsibility. I think those questions have already been asked. Is there anything you want to add?
So, Mr. Thompson, you basically made it clear that in the digital arena, it's you who is responsible for signalling to the, let's call it the innovation community, unmet needs within the NHS. Is that correct?
Yes, I'm accountable for digital data and technology.
Could you give us three quickly?
Sorry, say that.
Could you just give us three quickly? Current unmet needs with the NHS, which technology in the digital realm could potentially make a difference to, for which you do not see a solution at present.
So, I mean, the three that are active at the moment, really. So there is an unmet need specifically to be able to see more patients more effectively, right, which is fundamentally the AVT element of it. There is the example that Minister gave earlier about the introduction of AI to support radiologists in being able to make assessments about X-rays and CT scans, which was rolled out to, I think, 66 of the acute trusts, and we're now looking to roll that out further. That's a decision support tool. Fundamentally, that's using AI to identify issues within the scans. And then I think the third one is a different kind of one, which was mentioned again at FDP earlier, which was around using AI and machine learning to help in the optimization of the running of the system. So they are primarily focused at the moment around what I would call operational performance or decision support. And I think this is a really important point. My observation, having come into the health system again fairly recently from other departments, is that we seem to be worried that we're taking decision making away from clinical people, but I've seen no evidence of that in the use of AI and digital. If anything, we're trying to basically use that technology as a support tool and a decision assistance tool rather than a decision making tool in its own right. And I think that's really for me, that is the right side of the line to be on.
And final question, Minister, the closure of NHS England, how, and its integration into the department, how is that going to affect this process?
Well, it shouldn't affect this process because this is a clear commitment in the 10-year health plan. The life sciences sector plan rollout has also got this, and as part of the government's industrial strategy, life sciences is an important part of that. And all the work that we're doing is about not sort of stopping and starting or changing course, because you can't do that with this big transformation projects. The work of NHSE and what's going to happen is ongoing, and that's for the Permanent Secretary piece of work that she's undertaking. But I can assure you, given that this is in my brief, that I want us to accelerate and go at pace, because I hear your concerns around that innovation and adoption not getting into the NHS. We have we're in a unique position here in the United Kingdom in that we have the NHS where, absolutely innovation should be adopted. I'm amazing. I've learnt in the brief just the phenomenal work that in science and research that we are doing, and why the UK is the best place to come and not just discover, but to scale, adopt, manufacture the whole of it, whether it's medicines or whether it's medtech, health tech. But I do accept that there is lots of areas where there will be unmet needs, and in the end we've got to look at the areas where mortality is highest as well, and prioritise whether that's heart disease, as I said earlier, these sort of areas. But it's about that whole journey. How do you support clinicians to do their jobs much better? How do we increase productivity? None of us want to see a patient that gets thrown in. The FTP, the reason it's important is people have sat on a waiting list which is stuck in a drawer on somebody's going through it. Now actually what the AI can help you do is prioritise the patient whose symptoms or clear concerns are really serious, so that they know that even though they've been sat on a referral, that referral is going to get bumped up because they need treatment right now. And so, yes, if I can assure you, I am excited about this brief, and I want us to be rolling out much more innovation across the country as we can.
Good. Lord Ranger is coming in with some fresh questions.
Good morning, Minister, and to your colleagues. Thank you for your time today. A few questions about the Health Data Research Service that the government has announced £600 million of investment into, and which is due to be operational this year. Many people are asking the service to do many things already. What will be your key priorities for the HDRS, and what do you see it achieving over the coming years, considering the importance of data and research?
Look, if we want to lead on personalised medicine, if we want to lead on AI, then access to high quality data is really essential, because you just cannot do that. So HDRS is going to help researchers sort of generate the evidence that they need to understand, do new treatments work, are technologies safe, and how can we get sort of proven innovation to patients much more quickly. So the HDRS is going to build on our existing strengths already. So that's the genomic data that we've got, it's the diagnostic data we have, we've got lab data, and we've got lots of other health research assets. So that primarily is going to create the foundation. The HDRS is now incorporated, so this is going to be a real integral year in terms of getting things moving. But I also have to consider in my role public trust and the safeguards around HDRS. Yes, this is an AI national body of data, but rightfully so, many of you and many of our constituents will be wanting to know, how is that data going to be used, and is it going to be safe? So like the public trust issue is the thing that's on my mind quite a lot. But inevitably, patients do want their data to be used to improve outcomes, and they want it for everybody. And so I think when we explain to people how that data is used and what the safeguards are, actually the British public is pretty much on our side, because they can see what it means for future outcomes. So that we have a chair, which is Melanie, she's the CEO, and Baroness Blackwood is the chair of the HDRS.
So they've come to our committee already.
Oh, right, okay. So this is about, bringing our world-leading science. I want to see companies come here and invest, not just to take our innovation and discovery and take it out and manufacture elsewhere. I want them to do all of it. HDRS is absolutely a game changer for the UK as being the place to come and invest. And I was at Biotech Conference in San Diego, and actually so many companies are really, really looking to what this will mean. so this is not just about having more data. Let me just be absolutely clear. It's about how do you use the data safely to deliver better care. I'll stop there.
Lord Ranchik, you want?
Yes, just to come back, and thank you for your point on public trust. I think one of my colleagues will come back to you on that, but also on the self-funding decision that's been made after the initial budget is invested. Mm-hmm. How did the government come to that decision to enable HDRS to become self-funded? And if that does happen, how will that be balanced with the sort of economic benefits, but also the potential barriers that that economic model could present to people becoming involved in terms of access fees and charges to that data?
No, this is a really important point, and actually the conversation I've had is that there has to be a commercial model. I know that so many companies around the world will pay for this. And so they should, because this is money that goes back into our health service. I also have raised the issue about making sure that SMEs can access it. It's not just about universities who know how to understand the data or the information that it provides. We've got to democratise the data. That is so important in order for it to be available to, as you rightfully say, not just the big companies. It is about the SMEs, making sure that they will equally have access to it. But I'm sure you will agree with the investment that the government is putting in. We have seldom do we think about the commercial incentives of this. And I know people want their data to be used for good. Of course they do. But this is taxpayers' money. And we are helping innovation, and really positioning the United Kingdom. There's got to definitely be a commercial model. We haven't got that. We don't know what that looks like at the moment. This is the conversation that I am certainly having. But I'm very much of the view that we need to have something that's fair, that equally recognises who's going to be accessing and using it as well.
Just one follow-up to that then.
Yeah.
Would there be any consideration about sovereign businesses, so UK-based, especially SMEs, where we know that there's a challenge in the UK, that be an approach to that model? Is there some consideration about that?
No, that's a really important point, and let me just be absolutely clear. We want British businesses to absolutely benefit from this data and help them, whether it's research, scaling, adoption, clinical trials. It doesn't matter where they are in that service whole industry. Those that need access to it, and absolutely 100% British businesses will definitely be integral to this.
Thank you. You've mentioned public trust. Lord Berkeley has a question.
Thank you, Chair. Minister, you mentioned quite a lot about public trust in your last answer, but occasionally there is a breakdown of public trust, and so what are you doing to maintain the public's trust in how the health data will be used with HDRS?
So we are still working on the detail. Cybersecurity will be certainly something on many people. What if there was a breach? Who will have access? How will that be used? Will it be anonymized data? Do people have to opt in? All these questions will form part of the basis of how we engage with everybody, whether that's GPs, trade unions, the whole clinician workforce. We've got to do better communication on this, because actually we want the British public to be proud of the wonderful work that we are doing, and quite seldom many people just don't know what we are doing, and we have a wonderful story to tell. We must tell it, but equally we must have the safeguards, and we must listen to people's concerns when they raise legitimate concerns around safety and around trust of their data. And I think if we start that communications now, before we start delivering things and bring the British public on side, then that is absolutely integral to do. I am really minded to get on with doing that and not waiting, because I think there is a conversation to be had with the country on something that is so innovative and so unique, that really positions us as the place to come and invest and certainly bring your innovation to.
Ernest Jones.
So a number of the people we've heard evidence from have said that there's a problem with accessing data because of the legal framework that currently exists. During COVID, we managed to overcome that. The Secretary of State intervened and people had access to the data very quickly, but we're not in that position now. Do you see the HDRS as having a responsibility as the data controller for that evidence going forward. And one of the problems that we've had is access to GP data, the 6,000 GPs. So will the HDRS be able to provide some cover for them in terms of bringing all that data together to make sure that there is a proper legal framework and that GPs don't have a responsibility for making those day-to-day decisions about how to share their data? What's the kind of framework you're imagining for that?
Yes, I'm going to bring Rob in because there's a lot of work that needs to be done, because all of these different, all of the data systems will integrate with all the other things that we're doing in the data tech brief. So the electronic patient record, the single patient record, the HDRS, and then NHS Online will all have to have a system that integrates itself. And so on the electronic patient record, the data controller is still the GP. They will have to give permission to share that data as part of the single patient record, so it can be pulled into the NHS app. It can also be part of NHS Online. And we've got to make sure that the legal bits don't become barriers, and make it very clear who is the data controller and how that data, when it's shared, is absolutely going to be used. And that's the work that we are doing now, because we haven't built the single patient record. We're doing the work on sort of the architecture of that. Equally with the NHS app, all of that work is starting, and that's why the communications piece of getting the country really engaged with this, because there are a lot of bits that all interact but are likely to be coming out at different points, and that's why I think we have got a big piece to do. Let me bring Rob into that, because that's his team's work that they're doing.
Just before Rob comes in, can I be clear?
Yes.
Following up from Baroness Jones's question, is it your intention that HDRS will be the data controller for GP data?
Can I answer that question?
Yes, let me ask.
So we have to work out who is the data controller for what, and you have to get very, very specific. Now, if HDRS's role is predominantly to give very, very large data sets or work on large data sets that are anonymised for longitudinal studies, multimodal type studies, then they will be a data controller for that data set, which is probably anonymised. I think when it comes to the specifics around the GP and the patient record, that will be handled as part of the single patient record programme, which is under my portfolio. GPs will still remain to be data controllers for GP records. I think when we pull in that data as part of the single patient record, we will also become a data controller at that point, and I suspect it'll be a technical mechanism which will then transition that data for secondary purposes to HDRS, and the nature of what that data is and how it's stored will be determined about whether it is actually anonymised or not. My sense is that architecturally and technically that will be anonymised data that they are working on, not the actual patient record itself.
But is that a problem? We've heard several witnesses saying that the GP controlling the data is a major barrier. Do you agree with that?
The GPs currently are the controllers for their patient record. Some of them, as I understand it, are probably uncertain about what that means in terms of the single patient record and HDRS. I have to go out and solve that problem, frankly, which is to make it clear what the information governance, the data controllership, data processor relationships, and then the actual architecture for moving the data around the whole system. That's one of my things to fix, Lord.
Thank you.
Chair, I think you raised important points, because not all GPs are in the same space. Some will want to share and give permission, retaining data controller, but actually sharing that as part of the SPR, and that's why the communications piece is so important, so we can address any kind of concerns that GPs may have in terms of how that data is amalgamated into SPR.
But you wouldn't go as far as saying that you would mandate that GPs should not have control of the data?
I think it's in the bill. I think it's the secondary uses is covered in the health bill under the single patient record. So if the bill goes through with the secondary uses being accepted, then by definition that would be in legislation at that
Okay,
point.
thank you. Baroness Jones, do you want to carry on?
So you've already said that you believe, Minister, that there should be some sovereign AI capability, but can you explain what the scale of that? Because there is a huge dilemma here about how much we harness the great advantages of the data we have in the UK and use it to our own advantage, and to what extent we share it with the world. So there is a big ethical question here. Tell us how the government is going about solving that, and what would be if we did agree that there should be a significant sovereign AI capability, what would be the governance of that? How is that going to be controlled?
Yeah, let me, I'll bring in my official on that. I think that, look, these are really important points, because some of it is, many universities will really know how to use the data versus others, and that's where the sovereign bit becomes a bit of a challenge, and that's why the democratizing of the data, so that we make it usable and we understand what researchers or what various companies or SMEs actually need from the system. So we are absolutely making sure that the data is usable, because at the moment you can take lots of really good examples. You'd have to be an absolute expert in terms of being able to download that data and knowing how to use it. And this is where the communication with industry, with SMEs, with universities is really integral. How do we make sure the data is focused on the things that we really need it to be focused on? How do we make sure that SMEs have access? And that work with the industry is really, really important, understanding some of the barriers that they've faced or some of the concerns that they have. Let me bring in, but this is the work that's starting, just to say that, this is the conversation I'm definitely having with Melanie, starting to look at it. I mean, it's taken a while for them to get incorporated, but yes, of course, this is a really important point.
Minister, do you mind if we got more questions? Can we move on to the next question? Unless Rob, you have something you'd like to say?
I was only just going to put,
Can you be very brief, please?
It's a very technically complex area. So data ownership and data control sits with the NHS. Hosting of technical infrastructure is where I think people think about sovereign, is generally with the cloud providers US based at the moment, because they are providing the best cloud services in the world. And then the AI models, they can come from anywhere. So we could have sovereign AI models that are used in the system. We could have AI models from different states, from different companies as well. They are all different parts of the structure, and we have to think carefully about how we build that structure.
We want to move on to regulators and regulation. Lord Stern.
Thank you. And again, thank you very much for coming. The MHRA and NICE are obviously under a lot of pressure around resources, particularly in the context of the areas we've been discussing, which are moving so quickly, personalised medicine and AI. Lawrence Talon, the CEO of MHRA, came to us last week, and he had a range of interesting recommendations around funding, including, for example, charging a bit more for some timely, quick responses. He also raised issues which you mentioned, Fiona Bride, around other regulators being involved in AI because it's sort of device-like rather than drug-like. Will you be engaging with those ideas? I'm sure you must have heard of them.
Yes, can I say I joined Lawrence Talon in San Diego on the Biotech Conference. I have to say that the regulator is really moving at pace and recognising some of the challenges. The fact that the FDA will now have an office in London and MHRA will have an office in Washington, and recognising FDA-approved products is a real game changer. It's recognising what the industry, where we can streamline and work together much more effectively. But let me bring in Fiona, and I'm happy to answer any other questions.
And I think this is fundamental. We have to speed up, and clearly, as you rightly allude to, Lawrence is championing that. But it's also about bringing NICE as the health economic evaluator, but also NHS England. And I think what we see much more closely working is that integrated approach, particularly in medicines, but I think more and more so in the health tech space, to look at the horizon scanning, to determine which of these innovations are going to be really transformative. And to your point, where do we really want to lean in, go faster, look at a different maybe a more risk share, gain share type, innovative procurement, like we do in medicines, where we may go into a managed access forum, where we may look at collecting more evidence to further inform what then needs to happen. I think the same can be true in some of the health tech space as well. It all links back to how we need to evolve, how AI starts to inform what is possible. I think what Lawrence is clearly doing well is this championing of we have to evolve, we have to iterate, we cannot just have a process that is fit for purpose maybe 25 years ago and is no longer fit for purpose now. Yeah. And that is the evolution that I think we're really committed to see.
So Lawrence and I are highly aligned on the AI side of things. It's about being pragmatic. And so, for example, we've made some decisions in around the ambient voice technology, which we both recognise is an administrative tool and therefore is not something that would warrant severe scrutiny from MHRA. Conversely, we both recognise that when it comes to anything that is doing diagnostic or triage-related work, there does have to be some oversight, but the point-in-time approval is not at all appropriate for the pace of innovation. And I think we are both aligned on a process of what we call continuous assurance and evaluation.
Yep. And he also emphasised reflecting that need for speed in the charging process itself. My next question is about NICE. Now, you'll have to excuse, I'm a professor of economics and being slightly nerdy here. But it matters, it's a big point. Yes. And that is, NICE works mostly with QALYs, quality adjusted life years, and that is directly focused on the individual gains from this treatment. Of course, we all know that there are economy-wide gains from treatment. Yep. Mental health, a big example, but many more. And it just seems very odd, and I have to say I used to be in charge of the Green Book when I was head of the Government Economic Service 20 years ago. It was very odd in an assessment of the value of treatments, leave out those wider benefits. Now, we were told by the CEO of NICE that was a matter of government policy, that you must have a chief economist or somebody in the department who would be quite capable of working on those higher benefits. And as I say, I was in charge of all the chief economists, and my encouragement then would have been just, well, get on with it. Don't wait for anybody to give you permission to do that, because it's so substantial. What do you think?
Yes, thank you. So I think, this is a recognised challenge. We are only looking at the value in isolation of QALYs, as you quite rightly say. You'll have noted last week, certainly in the medicine space, where the conclusion of the sprints that came out further to the collaborative approach with industry, NICE have actually committed to looking at some of those productivity gains, piloting some of that, and also re-looking at all of those aspects. So I think we recognise that we need to think about the wider societal benefits, whether it's workforce productivity, whether it's maybe carer benefit as well. We need to make sure the mechanism is correct. Clearly the value and the pricing associated has direct correlation there. I think what I would also say is there is a question about, have we got the methodology right for how we apply it to health tech? Is it the same methodology? And I know that Jonathan Bender has already started to think about what needs to be true for the NHAP process, and does it follow medicines as closely as maybe it has done to date. So in terms of Green Book, I'm not going to specifically comment on whether that's right or wrong. I know people are looking at it, and clearly that will be something that's ongoing.
If this is a major change in the way NICE evaluates, could make a very big difference to not only overall resources but allocation of resources. If I understand it, you're saying you're getting on with that at pace, and you're encouraging that change to take place.
And the commitment was made last week with the conclusion of the sprint process further to the US-UK medicines agreement.
Lord Barclay, you want to come in on...
Thank you, Chair. We've heard from some witnesses that the regulatory approval of an innovation does not lead reliably to NHS deployment. And so is there a gap between MHRA or NICE approval and the actual commissioning and procurement? So what's the government doing to close that gap? Because it's obviously of concern to many people.
Yeah, no, it's a really important point. It comes back to the point of the adoption per se across a number of issues in the NHS. I mean, the MHRA has done some really good work. I have to say it's a regulator that lots of people around the world really do respect. I think Lawrence Talon has done a lot of really good work. And some of the things that they're really helping, especially support confidence in terms of innovation, is the MHRA have got the AI airlock. What does that do? Well, it allows innovative AI products to be tested in controlled environments. So, you know, it's bringing together the regulator, the clinicians, the industry and technical experts so that healthcare settings can absolutely have confidence that the AI performs safely in real-world settings, because that is the concern of a lot of the adoption barriers. And then the MHRA has also established the National Commission into the Regulation of AI in Healthcare. Again, this is about bringing together NHS organisations, technical experts, and they are trying to feed in terms of what does that future regulatory framework actually look like. And those are the kind of conversations we need to have, because we know, as Rob said, you know, this is a fast-moving area and regulation has got to keep up to pace while we protect patients. Because in the end, it is about patient safety too, right? So, honestly, I take on board the point that you make, because the adoption bit is the bit that we absolutely have got to get right.
What's your timescale on any of this?
I definitely want to put some timelines on it, and you know, there is lots of pieces of the jigsaw that all sort of fit together, especially in the data tech brief on the AI adoption and innovation. It comes back to the point around how do we make sure that what we are scaling up works effectively, shows the gains that we want to make, and then we do the rollout. And certainly that is the kind of shift we're taking. Has interest, rumor.
I don't know what that was, Minister, sorry.
Thank you so much, Lord Barclay.
We're conscious that you have a limited time. We've got a few more questions we'd like to ask. Are you able to stay for 5 or 10 minutes longer than the schedule? Thank you very much. Lord Vergie.
Thank you, Chair. Thank you, Minister. The government has set up a national commission into the regulation of AI in healthcare. When do you expect to have a proper framework for regulating the use of AI in healthcare? Will this involve moving regulation of AI tools into MHRA and away from the current system? And how do you deal with the challenge of such a fast-moving pace of innovation and regulating that?
Yeah.
So I'll pick that up. So Lawrence has commissioned this work himself, which I think is a really good thing, and it's needed. I understand that the review and the report is likely to come out in September. That's the last time I heard that he was going to formalise what they'd found. They have been good in outlining what they're finding in an interim basis, and I think there's kind of like 3 things that come from there. The first one is that they're not just only considering the risk of introducing AI, they're also looking at the risk of not introducing it and the negative impacts that have on patients. I think that's a really profound shift, because ultimately it's looking at the counterfactual, isn't it, and just saying, actually, if we don't do this, how much harm continues potentially. So, and I think that's a very bold and ambitious thing for Lawrence to do, and I think it's actually very badly needed given the pace of change in this in arena. I'm in agreement with Lawrence and the interim findings that we need to move away from the point-in-time approval and accreditation process and find a way of continuously improving AIs that are deployed, recognising that they will in themselves evolve and get better. And I think Lawrence's current view of this is to frame the nature of how much an AI can evolve without it having a full review, and I think we're going to have to learn by doing on that, because I think that's going to be an experiential thing. And then,
are there any further points, or can we move on?
The third point is basically the regulation should be context specific for the AI as well. So review September, recommendations come out, we will probably build a plan from there.
Thank you. Lord Winston.
Workforce,
indeed.
we've heard repeatedly in this committee about the time that clinicians are having to devote to things which actually prevent them from really deploying innovations in the National Health Service. I wonder really whether you'd be would you care to comment that what we have also heard is that one of the most important ways of ensuring better medicine generally is to have more academic clinicians. Let me define what I mean by an academic clinician. That is somebody who is on a career path to a consultant appointment generally in the NHS or to an equivalent scientific appointment, who has training in both science and medicine. So a PhD, for example, also a member of the Royal College, one of the Royal Colleges, whichever. Now, there is a massive shortage of the number of clinical academics, and certainly that, I think, is a major problem. They spend 5 years at least in post, and they're not being properly funded. Sometimes, I must say, NHIR has done a very good job in actually trying to fund them, but on the whole, there is completely inadequate support, as is shown by the college, the College of Medical Sciences, for example, the Academy of Medical Sciences, I should say. What do you think we could do to ensure that that is increased in the NHS? Because they have a massive effect on departments. They also do important clinical work at the highest level.
Yeah. I think this is a really important point because, you know, clinical academics, as you say, are vital to the UK health research. I'm very privileged that I represent a constituency which has the largest hospital trust in the country, and it sits next to the University of Birmingham, and then you've got the Health Innovation Campus, and it's a training and research hospital trust. But that's not replicated everywhere, and we don't have the benefits of that. But the National Institute for Health and Care Research, as you've rightly recommended, they are the largest funder of sort of clinical academic training, and I think that is really important because, you know, they invest over 230 million every year in research training programs, and it's, to your point, it's about how do we retain, how do we support those clinicians that have both of those different skill sets. But there is going to be a new research workforce update because there is a recognition that across the country the landscape is it varies, and that will be published, I think, in the there isn't a fixed timeline, but I think in the coming months, in a couple of months, there is a view to bring that in. But there's also, the NIHR has an academy. So there are lots of different things that the NIHR are doing, and what they're responsible for is the development and the coordination of some of the academic training that is going to be available, but also they do research capacity, they look at career development. So there is a lot of work that is actually being done in this area. There is also money. So in the personalised medicine space, there's about 17.9 million to do this piece of research.
Grateful to you for giving us so much time, but I really want to concentrate on the specific issue of clinical academics, because I think they really are the leaders in this area. For example, so many major advances in the health service, the whole of, for example, care of neonates was completely changed by clinical academics. This applies to many areas of surgery where people are employing, and it's certainly one of the most interesting aspects of innovation has been in vitro fertilization. In vitro fertilization is a $35 billion industry. We get no money at all from that, even though we developed it. In fact, actually what has happened, partly because of regulation, which I think has been misapplied, it's been more and more difficult to get licenses, and also more and more difficult to get the work into clinical medicine inside the NHS. That's actually now ignored completely. And really, that's completely inadequate if we want innovation. We should be encouraged, because there's a huge amount of innovation to be done, for example, in things in genetic medicine. And one of the things we've heard again and again, that the two greatest areas in the workforce that are really important, one is imaging, which of course includes what we've already talked about, which is radiology, and not only radiology, but mainly radiology, and the other, of course, is genomics, and obviously the use of genetics generally. Now, it seems to me that those are two areas which are really being mostly pushed by these sorts of employees. But actually, there just is not enough money in the current pot. And there used to be other monies from research councils, which is no longer available, nor indeed from the Wellcome Trust. But it's really urgent if we have some kind of recognition of that quite separately in the health service, in my view.
Let me just be clear. I think the points you raise are really, really important. And I do recognise we've got to strengthen this workforce, as you say, if we want to sustain the capability of the United Kingdom. And that's why the workforce update piece, in terms of making sure how do we recruit, how do we retain, how do we fund, and make sure in the areas that we're pushing through is there. So, I can share with you when that is likely to come, but it is due in a couple of months.
Baroness Willis, you have a point about training.
A very small point, really, and that's to do with, of course, this is the current medics and current clinicians, but of course you've got those going through their 6-year training programme where none of this is covered. And so how, or at least my experience and the evidence base I've taken from others, how are you going to manage to weave this into the training programme now so that the next generation come through are able to really embrace these technologies without seeing them as some sort of something that's not for them?
Yeah, I mean, look, this is a live conversation, and I think you're absolutely right, because the whole workforce piece in terms of where we need who with what skills is really, really integral to being able to do some of the transformation work that we want to absolutely do. But there is a focus on the genomics capability. How do we build that workforce? And so there is a structured NHS genomics education programme offer. So that is available. This is very much about how do we work closely with that sort of neighbourhood health teams, recognising, how do genomics help? How do they improve preventative and sort of the preemptive healthcare piece? So that programme is directed very much in that space.
Sorry, so it's an offer. Does every health trust need to take that up? In every medical school, are they going to be teaching this?
It's something I will take back. I think it's a really valid point. Yes, no, I'm happy to.
Lord Ranger.
Can I come?
Minister,
I haven't yet finished.
Oh, sorry, Lord Winston hasn't finished.
Forgive me. We've also heard that there's, the two great advances of undoubtedly imaging and the other being genetics. In both cases, the staffing for both those areas is inadequate in the health service. There's a desperate shortage of clinical geneticists, and on the imaging side, according to the Royal College of Radiologists, there may be as many 3,000 jobs short at the consultant level. That's a huge proportion that is actually needed in that area. That's only just for them, but it also applies, of course, to pathologists, which, of course, is the other area which is closely related. And indeed, we still have large numbers of chairs, maybe 20% or more of the chairs not filled in that level, because, in fact, we're not doing enough. And actually, that is a responsibility, partly to ensure that's integrated in the health service.
The department's workforce strategy overall is due imminently. I mean, it is ready to be announced, I think, and that is recognising where we need everybody in terms of like where those gaps exist. But in particular, in terms of this area that you focus on, there is a recognition that we do need to do more.
We're going to increase needs for better innovation. Surely this is actually an essential requirement.
No, you're absolutely right. It is really, and there is a recognition that underneath the overall workforce strategy, we absolutely need to have the research workforce update, and that is the bit, as you allude to, we are working on.
Lord Ranger. Minister, I want to congratulate you. It's in 7 weeks. You seem to have really approached this brief with gusto, and your excitement is palpable. And you've got a lot to deal with. We all know the NHS, the technology, the innovation, the bureaucracy, the organisations. My question is about the voice of the patient. We've had quite a broad-ranging discussion today, and even in the 10-year strategy, where is the voice of the patient in terms of their experience? I say this as someone who spent the best part of 30 years delivering major public services using technology. I'm not a techie and I'm not a commercial person. You have those people with you. But the voice of the patient, the user experience, the customer experience, in this case, the patient experience, will be fundamental to any success that we see happening in this area. And you mentioned, there's 41 million people using the NHS app. I've used it recently. My experience is not great from the app. And this comes, you mentioned comms a few times as well. If I was to say that my average fitness app with much less data gives me a much better experience and understanding of what's going on with me than the NHS app does, I think you know where I'm coming from. So where is the focus that you're going to have in all the things you're doing around what we call the UX, the patient experience, how that can be fed back in, how they can feel that they have some control and understanding of what's coming? And actually, we talk about precision medicine. Isn't this about personal well-being and the language that we use to describe what's going to happen?
Yes, well, can I just say, Lord Ranger, thank you very much for your kind words. I have to say I have probably one of the best briefs across Whitehall, and it certainly, health touches everybody's lives in some way, and it's a real privilege to do this brief. It's really exciting because I think the work that we're doing, especially in the data tech space, is revolutionary. It's going to change people's experience of the NHS and how they sort of navigate through getting various treatment pathways. But the question you raise is really fundamental to everything that I do. My brief is Minister for Innovation and Patient Safety, and it's the patient safety from the constituency angle as a Member of Parliament that I come to every single question. What does this mean for the patients? How is it improving patient outcomes? Where is the voice of the patient in terms of the things we're doing? And that's why I think the communications piece is vital now, having the national conversation about what patients accept. You're absolutely right about the NHS app. I think there are some really good things it does. If you can get a GP appointment, brilliant. You can see your blood test, you can see your appointment letters, but there are lots of people that are excluded digitally as well. And so a recognition of rural areas where Wi-Fi is not always brilliant and the infrastructure is not there, how do we make sure that those people are equally very much part of being able to have access to healthcare? And it's interesting, the health and well-being. I mean, I want to be ambitious, and the NHS app has got to do a lot of things because it's integrating. It will be part of the single patient record. It will be part of the NHS Online. It will be part of the HDRS. But we've got to take the country with us, right? And we've got to be talking to groups. We've got to talk to you, the Lords. Really important. Lots of expertise and experience in how you, use the app versus, what clinicians think. How easy is it actually for the app to sort of the interface of it? You share about your Fitbits and things like that. You're absolutely right. I mean, what that can produce versus what should be on the NHS app is really, really important. So, let me be clear. I'm absolutely ambitious. I want the patient voice to be central to this. As do we, and that's why I think a consultation starting now, having that national conversation, engaging so many, and young people as well. There are so many people, and we can learn from, I suppose, the social media ban, a piece of consultation and work that was done in DCIT, just how integral that was and how integral it is to bring people with us, because all of us want to see outcomes improve for patients. Rob, can I bring you in?
Yeah, so Minister makes a good point about where I would say en masse, what people think about the NHS app. And there's high variability in there. I own the delivery of the app, I own that team. There are 170 user-centred design people that work in that area. They have access to about 50,000 people through focus groups and experiments and labs to be able to figure out just how people will or won't use the service. So when it comes to UX type activities, I feel like I've got good depth in being able to make the app as good as possible. One of the challenges that we have is connectivity into data and other systems within the health system, particularly in and around GP IT systems, which is where a lot of the records sit. That's why you get variability in the app experience across the country, because some GP systems are not very well connected in and others are.
Mr. Thompson, may I interrupt you for a second?
Yeah.
When did you last use the app?
Last week.
Well, it's not relevant.
Lord Ranger, we've got so many more questions.
Okay, just one point. On blood tests, you can get results back they're not in a language that a general person could read, and then they send you off to NICE to work out what does it actually mean. So I think all those 170 people, there's something about how you get that experience from a user perspective that I think is slightly missing there.
Okay. I think we must move on. Minister, you and your officials have been extremely patient. We're reaching almost the end of our questions. Lord Drayson.
Thanks, Chair. This committee has looked, not just in this inquiry but in previous inquiries, as to how the government supports domestic UK companies, and including within that life sciences companies. And the evidence we've received is that the experience of UK companies is really negative. So much so that if a company sets as its business strategy to focus on being a supplier to the NHS, the venture capital community does not want to invest in them. And we've seen evidence from leading medtech, AI, life sciences companies that have had much more success in achieving procurement wins outside of the UK. Yeah. Now, Minister, you've joined a department which has a track record of not buying British. If we take in the IT space, Mr. Thompson, you say how cloud hyperscalers are world leading. They are world leading in the UK now because they so undercut the domestic industry 15 years ago that the UK companies could not compete. And we're now going through that again with AI. So, Minister, to the point of trust, an attitude survey in the UK just 2 weeks ago on AI showed that the British public want politicians who are in control of the way in which AI is deployed in their country, that respects the issues that are important to the general public and therefore as patients. And they're very concerned from this survey as to the way in which the alignment between the US administration and US big tech has been used negatively. And we see how the government has recently adjusted the NICE value for money thresholds as part of its pharma deal with the United States. What I'd like to hear from you, Minister, as a relatively new minister in the department, your enthusiasm or otherwise for looking again at the way in which the NHS procures technology, medicines across the piece to help favour domestic industry. And what are you doing now to basically change the environment such that it more aligns with what the British public want?
So thank you so much for your question, and it's a really important one. The first thing I did when I was newly appointed is ask, is there a British alternative? Can a British company do this? And absolutely, we must buy British. There are lots of really good companies here. Look, in the end, the NHS's procuring capability, and it's not really focused on, who the kind of company is. There are companies that are not British companies that partner and have a consortium with UK companies so that UK employees are working on. The FDP is a really good example of that. But you're absolutely right. I want us to absolutely give confidence to British companies and be sort of tapping them in terms of letting them know that there are these procurement opportunities so that they can bid for them successfully.
But Minister, a previous Labour government made a decision that it needed to maintain a nuclear capability by providing orders to Barrow-in-Furness shipyards so they could continue to know how to build submarines. If we want to have industry in this country able to meet the strategic needs of the NHS, your department has to spend money with them.
Yes.
So what I'm looking for is what action is being taken now, because this is an urgent here and now problem. What is being done now to change the environment such that these businesses can have confidence that the NHS is stop going to be buying American tech?
So I think this is a really important point, and this is what the Life Sciences Sector Plan is seeking to do. We've got to make sure that the whole pathway is available. What I don't want to do is see in my university or in my area medtech companies or startups having to sell their innovation, and it's then made out of the country, it's taken out of the UK, it's manufactured out of here. I want us to be the best in clinical trials.
I'm sure you do, Minister,
but this is the work we are doing.
Genomics England is storing all of its patient data on an Amazon Web Services data centre, which comes under the US Cloud Act, and therefore is under the control of the US administration. Unless your department takes decisions to build this infrastructure, then you're only left with the choice to use these solutions which go against what it is that the public wants.
I think some of it is about the value for the taxpayer. So there's two questions that you asked me. So let me just address the first one. In terms of the life sciences sector plan, in supporting startups to get the access to cash, to have the innovation, to build the ecosystem of what the service industry around life sciences looks like, we have a lot of brilliant UK companies doing some great innovation. There is the National Wealth Fund monies, there's money across DCIT to support, there's the manufacturing fund. There is actually a lot available. What isn't always clear is how all of this integrates and how SMEs or British companies can access to scale up in the way that they want to and get the adoption that they need into the NHS. These are the things that we need to absolutely get right. On the sovereign capability, we've got to make sure that companies can deliver. There is a lot of companies that absolutely are going to be, pitching for the procurement on single patient record. We absolutely, I want to be clear, I want British companies to be bidding for that when it comes out. And it isn't all about the tilt to looking at other companies taking, doing the piece of work in the NHS in the way that is shared. We've got to look at where there is capability and capacity as well. The transformation that we are doing, and I take on board the point that you say, there are amazing companies who want to get into the NHS and are really struggling, and that's why the MHRA, NICE doing the work that they're doing collectively, having a pathway, being very clear as to what adoption looks like, is so integral. And all of this work seems to be happening quite simultaneously, but I'm cognizant of the issues that you raise.
Really good to hear. Could we turn to clinical trials? The UK is currently undertaking about half phase 1 clinical trials that it undertook 10 years ago. This is a pretty catastrophic decline in the picture.
Yes.
But there are early signs under the current Labour government that that's starting to stabilise.
Yeah.
Could you tell us what you're doing to reform this, particularly in the area of personalised medicine and AI, where there is clearly an opportunity for major breakthroughs, but will only accrue to the UK if the UK is the place where these new innovations are trialled?
You're absolutely 100%. Coming back from San Diego and biotech, I want the UK to be the best place in the country for clinical trials. The Prime Minister did set a timescale of 150. We've managed to bring that down to 122. That is not good enough. The recent Quell clinical trial shows you that what we can do. In 57 days, we were able to set up the first trial, and we did it simultaneously in 10 sites across the UK. Now, the NIHR has an industry hub. And the idea of the industry hub is really to support those clinical trials taking place. But actually 122 days is not good enough. We've got to be competitive. I don't want to hear people telling me that Australia or Spain can do it better than us. Actually, we can do it. And this is certainly the conversation I am having with the department around how are we going to bring those clinical trials so that the UK is the best place to come and do those trials. But not just phase 1, the whole of them. And that is important. And I know we've got the capability of doing it.
In terms of the sort of last question, if you like, comparators with what other countries are doing in the context of this massive change that's taking place, not just in the technology, but in terms of the geopolitics and the relationship between nations. It's interesting that other, particularly European nations, are taking a much more, if I may say, sort of muscular and robust approach in the way in which they choose their own industries when making procurement decisions. And we have heard how there is a cultural difference in the way in which civil servants within the UK, not just in the NHS, but including within the NHS, and civil servants within other countries such as France and Germany behave towards their homegrown businesses. Is that something you accept is a difference? And is that something which, in the current geopolitics, you agree needs to change?
I agree it needs to change, and absolutely we should be procuring from British industries and helping that wider supply chain. This is about creating jobs. It's about making sure that the innovation stays in the UK, that we can have the wider supply chain that supports that ecosystem, whether it's manufacturing and legal services, whether it's in the labs. This is a sector of growth. It's part of our industrial strategy. Absolutely right, that we should be procuring British. And I'm glad the Chancellor, really set that across Whitehall as a requirement. And we hear you loudly and clearly.
Thank you, Minister.
Minister, you've been really excellent, and thank you for extending the time that's been allocated for this session. You and your officials have both been wonderful in answering so many of our questions. You said earlier that you've got one of the best briefs across Whitehall. We wish you very well in your endeavours on that. Thank you so much for coming.
Thank you so much.
We'll close the session now.